This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation. Today's case is...
You have a 20-year-old otherwise healthy male presenting with dental pain that started just prior to arrival.
On further questioning, the patient reports that he was at a bar and intoxicated when he was punched in the face.
Here are his teeth.
Dental complaints in the emergency department are on the rise, and dental traumas make up the bulk of the acute complaints.
To start the conversation, we must know the vocabulary.
Adult dentition consists of 32 teeth, of which there are 8 incisors, 4 canines, 8 premolars, and 12 molars.
The adult teeth are numbered from 1 to 32, with number 1 being the right upper third molar and the remainder as shown.
Baby teeth, or primary dentition, are labeled A through T, with A labeling the primary right maxillary first molar, and the remaining is labeled here.
A tooth consists of the central pulp, which contains the neurovascular supply, the dentin, a microporous system of microtubules that serve to cushion the teeth, and the enamel, the white visible portion of the tooth.
The tooth may also be described in terms of the crown, which is the portion covered in enamel, and the root, the part that serves to anchor the tooth in the alveolar bone.
A number of anatomic descriptors are also used to better describe the surface of the tooth.
These include facial, which can be labial or buccal, oral, which can be lingual or palatal, approximal or interproximal, mesial, distal, occlusal, incisal, apical, and coronal, as seen in this diagram.
When considering dental injury, it is important to differentiate between primary and permanent teeth as the management is significantly different.
Primary teeth are completely replaced by permanent teeth between 6 and 14 years of age. Primary teeth are white and smooth, whereas permanent teeth are more cream-colored, larger, and jagged-edged.
In general, primary teeth require little or no intervention, as viability of the tooth is not a concern. Primary teeth, when avulsed, should not be replaced because of the risk of disrupting the normal development of underlying permanent teeth.
A concussion injury is when a tooth is tender to percussion following trauma, but is firmly in place. No intervention is required in the ED other than dental referral.
A subluxated tooth is loose but is in its original position and does not need repositioning, whereas a luxated tooth is displaced from its original position.
An intrusion injury is a type of luxation in which a tooth is pushed further into the alveolus. It is prone to infection, subsequent root disruption, and underlying alveolar bone injury. Treatment for intrusions in the ED involves antibiotics alone and follow-up.
An extrusion injury is a type of luxation in which the tooth sits partially pulled away from its alveolus. In this case, the tooth should be pushed back in line vertically with surrounding teeth with prompt dental follow-up.
Avulsion, in which a tooth is completely separated from its socket, requires careful storage and repositioning in order to ensure the viability of the patient's native tooth structure.
An avulsed tooth should be stored in milk or a specialized product called Hank's Balanced Salt Solution.
In the event that saline or milk is unavailable and the patient is conscious, store the tooth in the patient's mouth at the vestibule between the gingiva and buccal mucosa.
Once a tooth is avulsed, it is no longer alive. However, the bone structure of the tooth can remain functional for years if the root fuses with the underlying alveolar bone, similar to a far more expensive and invasive prosthetic dental implant.
For this process to occur, the tooth must be repositioned before the periodontal ligament, which is a highly specialized connective tissue layer that anchors teeth to the alveolar bone, becomes necrotic.
To reposition the tooth, rinse the socket with saline to remove loose debris, irrigate the tooth, taking care not to wipe directly the root surface, push the tooth into the alveolus with firm pressure until it is level with the adjacent teeth, and splint the tooth in place using wire and Dermabond.
Prescribe a soft diet, 1-week course of penicillin VK or clindamycin, and arrange for dental follow-up.
Tooth fractures are divided into 3 categories based on the depth of injury and the tooth layer involved. They can be referred to based off of the Ellis classification.
Ellis Class 1 is a fracture involving the enamel and do not require emergent interventions. Dental follow-up should be established within several days.
Ellis Class 2 is a fracture involving dentin and can be identified by the softer yellowish middle layer present on exam. These are accompanied by increased tooth sensitivity. These fractures require the application of a protected sealant and can be followed up within 3 days, although less than 24-hour follow-up is ideal.
Ellis Class 3 is a fracture involving the pulp and is typically evidenced by the presence of blood. These also require protectant sealant and dental follow-up on the same day within 3 hours is needed, if possible, as the permanent tooth may be salvaged by performing an expedited root canal procedure.
Fractures involving the dentin or pulp require a protectant sealant to prevent immediate pulp necrosis and to reduce pain. To apply calcium hydroxide or zinc oxide eugenol temporary cement, wipe the affected tooth with saline soaked gauze, dry the tooth, then fill the lesion with cement, taking care to maintain the contour of the tooth.
A gauze roll bite block can be placed to allow the sealant to dry completely for 15 minutes. Alternatively, cover the tooth with Dermabond and then wrap it in foil to coat the sensitive tooth structures.
Primary teeth with fractures involving the pulp will typically be extracted.
Large tooth fragments that detach in the context of a fracture can sometimes be reattached and should be stored in a milk bath until a dentist is seen. Try to account for all tooth fragments, as fragments may sometimes become lodged in the surrounding mucosa or aspirated into the lungs.
To summarize, as always, learn the anatomy whether it is the type of tooth, its position, the part of the tooth, or the surface of tooth involved.
Subluxation and luxation should generally be repositioned and splinted. However, the exception to this is the intrusion, which should be started on antibiotics with prompt dental follow-up.
Store a vole's teeth in milk, Hank's balanced salt solution, or even in the patient's mouth in the right clinical setting.
Remember the Ellis classification for tooth fractures. Class 1 is a fracture involving the enamel, Class 2 involves a dentin, and Class 3 involves a pulp. Prognosis and management varies depending on the class.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EML Lou.
Thanks for listening.